Good evening, friends and OBG residents who are joining this program. This today's session is going to be on operative surgery for carcinoma cervix. Basically, it is about radical hysterectomy and when we do it, how we do it, and what are the usual discussion things that happen when you have a discussion on operative surgery for radical hysterectomy. Now, it's a very common clinical scenario. Cancer cervix being discussed. It can be in the form of operative surgery. It can happen when you have a specimen of a Wertham's radical hysterectomy being kept for surgical pathology being discussed, or it can be for a clinical case discussion when you have a cancer cervix. So, any of the situation, you can have a discussion on radical hysterectomy and its indications and complications and so on. Now, the first thing you should know what is a radical hysterectomy. Radical hysterectomy is a procedure which involves en bloc excision of the uterus with a parametrium, the uterosacral ligament, the upper third of the vagina, and inclusive of a pelvic lymphadenectomy. So this is what encompasses a radical hysterectomy. So the types of radical hysterectomy will determine how much of the parametrium you take, how much of the uterosacral ligament you take, and how much of the vagina is being going to be removed along with the specimen. Now, this is the common classifications that are in use that you should all remember. And when you are asked on a question on radical hysterectomy, the commonest one that is still in vogue and still practiced is your Piper et al. Classification mentioned as early as 1974. The type 1 is your simple extrafacial total hysterectomy. Always remember when you mention a radical hysterectomy that BSO has to be mentioned along with it. So you'll say radical hysterectomy with BSO because BSO per se does not add to the radicality of the surgery. It is a part of the procedure as an adjunct rather than that being a qualification for calling a procedure as a radical hysterectomy. Now, type 2 and 3 depends on whether you're going to do how much of the parametrium you take, how much of the uterosacral ligaments you take. So in a type 2, classically, you will be ligating the uterine artery at, uh, at the crossing of the ureter. That will be the uterine crossing in a ligation in a type 2. In type 3, we will be ligating the uterine artery at its origin from the internal iliac artery. This is regards to the ligation of the blood supply. Next is your parametrium. In type 2, we will be clearing the parametrium up to the level of the ureters. And in type 3, you will clear the parametrium up to the pelvic side wall. With regards to the uterosacral ligament, so in case of a type 2, it will be midway between the uterus and the sacrum. And in type 3, it is close to the sacrum that you're going to remove the uterosacral ligament. And then the vagina. In case of a type 2, it is about 2 centimeters at least of the vaginal cuff that you have to give. People go on to say that when you take it up to the uh, 1/3 of the upper vagina, then it becomes a radical type 3 hysterectomy. Then you have the modifications or the other classifications in place, namely the Morris classification or the Kohler's classification, where you have a classification based on type A, B, C1, C2, D1, and D2. For the sake of simplicity, I'm not going into the details of these classifications because they are a topic to discuss in itself. Now, uh, in type B, it could be an extended simple total hysterectomy or a semi-radical hysterectomy. And type C1, if it's a nerve sparing procedure. Type C2 is what we call as a Meek surgery or a radical hysterectomy. And D1 and D2, when you do go beyond into the extended parametrectomy or adjacent endopelvic fascia resection. These are very advanced procedures that we do in selective situations. Now, uh, a crux of the discussion today is going to be on Wertham's hysterectomy, which is nothing but your Piper's classification type 3. Type 3 radical hysterectomy is your Wertham's hysterectomy. It involves en bloc removal of the uterus, the cervix, the proximal vagina, the paracervical or the paravaginal tissue up to the side walls, en bloc with the removal of the uterosacral ligaments totally, uterine artery ligation at its origin. So this is what we mean when we say that. When you're going to remove the parametrium up to the uterine crossing, that is a type 2. But when you're going to remove the uterine, the parametrium and the up to the pelvic side wall, it becomes a type 3. So whenever we go laterally, you should remember that the parametrial and paravaginal dissections can lead to some bladder complications. So this is something that you need to be aware of. So whenever you're talking about Badham's hysterectomy in an operative procedure, you should remember two important and anatomical spaces that you have to remember. One is the paravesical space, next is the pararectal spaces. So if you know these spaces, you are defining the anatomy. So pararectal and paravesical spaces you should be aware of. Now moving on to the classical indications of Wertham's radical hysterectomy. Now primarily Wertham's radical hysterectomy is done in case of stage 1B, 1 and 2 and selected stages in stage 2A where you can do a Wertham's radical hysterectomy. 1B3 when the tumor is more than 4 centimeters, even when there is no parametrial invasion, is a tumor not very suitable for Wertham's radical hysterectomy because these patients will definitely require adjuvant chemotherapy and radiation. Whenever you add on chemotherapy and radiation post-surgery, the survival, if it is compared with only radical chemoradiation, is no different. So by addition of two modalities, that is surgery and radiation, compared with only chemoradiation, you are not adding to the survival. And in fact, you are adding to the morbidity. When you combine both modalities, the morbidity is more. And in these situations, it is better to give chemotherapy and radiation. Now, as a selected situations in stage 2B, as a part of clinical trials, when we do give EBRT 50 grays and operate, yes, that is an indication for a Wertham's radical hysterectomy as well. Central recurrences after radical radiation. That is what we mean by central recurrences. A patient who's had a radical radiotherapy for a CA cervix, where we have completed the complete course of chemotherapy and radiation, and you find that the recurrence is very small, confined to the cervix without much of parametrial disease or paracervical disease. This is a patient where you can take it up for a Wertham's radical hysterectomy. And lastly, in case of a cancer of the endometrium, where there is a cervical stromal involvement that is made out clinically or by MRI, is an ideal case for selection for a Wertham's radical hysterectomy. Now, remember that radical hysterectomy is the standard of care whenever you choose a patient for a Wertham's radical hysterectomy. Now, most of the situations now, even though minimal invasive surgery has become the standard of care in endometrial cancer, it is not so to be the case in case of a cancer of the cervix. Now, what is the difference that you have to remember is in cancer of the endometrium, now early confined disease to the endometrium, laparoscopic or robotic radical hysterectomies results are very much comparable, if not even better than in selected situations than open surgery in terms of recurrence, recovery and early post-operative mobilization and so on. As such, the oncological outcomes are similar. However, in terms of radical hysterectomy for cancer of the cervix, we have evidences which has come from various trials and randomized control trials as well as series, which have actually said that laparoscopic or robotic surgeries, that is the minimal access cancer surgeries for the cancer of the cervix, seem to do poorly. And hence, we are not doing it as a routine. I'm sure that it's a matter of time before it is established that it can be done safely in safe hands. Why we are not doing it, I will come to the details of the trials and all that stuff at the end of this class. But remember that for the sake of easy understanding, I'm showing one of the earlier laparoscopic procedures I had done little earlier. Of course, now because of the various evidences which has come, we are not doing it routinely. Now, the laparoscopic or a robotic surgery or an open surgery, they're all tools in the hands of the surgeon. Irrespective of how you do it, the steps of the surgery have to be the same. And the first step will be the anterior U cut. So it is important that any cancer surgery, when we do, we have to make sure that we are dealing with a patient who has a resectable cancer. We don't want to be having done so much of the parametrial dissection and then finding that you are not able to separate the tumor from the bladder or the rectum at the last point. So it's important that we make sure that there are no bulky nodes. In case you find increased, bulky nodes, there is a chance of calling the surgery a futile one. Now, with the advent of MRI and very good imaging, as in the case of PET-CT and so on, we don't find such operative surprises. But in case of a doubt, we do send the lymph nodes for a frozen section. And in case the lymph nodes are positive, it is a controversial thing. Most centers will not continue with the radical surgery. Reason is these patients will anyway they need chemotherapy and radiation, having become a stage 3 cancer, and they may not have the benefit of the surgery. So the surgery starts with an anterior U cut, that is the UV fold of peritoneum is open, and similarly a posterior U cut. This is on the posterior side of the uterus and cervix. Once this is done, we develop the pararectal space and the paravesical space. Now, this is what we mean by the pararectal space. On either side of the uterus, uterus and the cervix, we develop this space and go up to the level of the levator neck. So you can find out that the rectum is free or not. So by doing the paravesical space and the pararectal space accordingly, you will make sure that the bladder and the rectum are free. This is the important step. Once you do that, you make sure that there are no involved nodes that you have already dealt with. Apart from that, the bladder involvement or the rectal involvement has to be ensured. The radicality of the surgery is ensured only if you do a proper paravesical and pararectal space definition. So this is what I'm talking about when you say about the pararectal space. So starting from the right ureter, we go in this plane between the iliac vessels and the pelvic side wall. We go up to the level of the levator. And next step is to ligate the uterine vessels. So in a type 3, ideally, you will be ligating the uterine artery at its origin from the internal iliac artery. Remember that internal iliac artery, if you have a doubt, which is the branch which you are talking about is the uterine artery and which is the superior vesical artery. Remember that the first branch which starts from the anterior branch of the internal iliac is your uterine artery. Whereas superior vesicle is almost like a continuation of the anterior branch. Posterior branches of the internal iliac artery are not easily seen. They have to be dissected and gone posteriorly. Only then you will be able to identify. So ligation and division of the uterine artery at its origin from the internal iliac artery is the next step. Once you do up, go up to the levator. So this pararectal space you develop and go up to the levator. So that will make sure that you have freed the entire parametrium. Now, next we go on to the uterosacrals and cardinal ligaments. The cardinal ligaments, in case of a radical type 3 hysterectomy, have to be divided close to the pelvic side wall, and uterosacral ligaments, as I already mentioned, in a type 3, you will be dividing it close to the sacrum. I will be showing a short video at the end of it, but it will be important that you know these steps. So, surgery is all about replicating these steps. Next is making a broad ligament window, cutting between the infundibulopelvic pelvic and the round ligament. When you do that, the ureteric tunnel ureter is visualized, and then we start doing the ureteric tunnel. Remember the 2-3 important things that you have to keep in mind. Ureter has a series of vessels like a plexus which comes on its surface. So never try to skeletonize the ureter or lift it up totally, because if you handle the ureter as much as possible, we usually handle only the periureteric tissue and not hold the ureter per se. We handle the ureter with any sort of vascular devices, in the sense I'm talking about energy devices, or you use forceps which are crushing, then you can have a devascularization of the ureter, or if you strip the ureter of its blood supply. So these are things that you have to keep in mind. So dissecting on the anterior surface of the ureter, slowly dividing the periureteric tissue on top of the ureter until you see the vessels which cross them. So this is the technique. You have to dissect the ureter until the level of the urinary bladder dome where it enters. Next thing is the clamping of the paracarpus. Once you have identified the ureter and divided the uterine vessels, ureter is pushed laterally, you will be able to divide the paracarpus. And finally, the opening of the vagina, that is a colpotomy, making sure that you give adequate vaginal margins. Usually the upper third of the vagina is given as the margins. Whenever a doubt of a margin of the vagina is in doubt, the always very simple thing to do is ask your assistant to do a per vaginal examination on the table. Of course, there will be a little bit of issue in terms of gas escaping, but if it is done, you can always make sure that the vaginal margin is good. Once it is done, repack the vagina and then complete the colportum. Finally, retrieve the specimen and then do a wall closure. Now, pelvic lymphadenectomy, there are people who will do the pelvic lymphadenectomy at the end of it, and there are few people who always do it at the beginning. I believe in doing the pelvic lymphadenectomy at the beginning of the procedure for two obvious reasons. One is when we do the pelvic lymphadenectomy, in case of a surprise of a suspicious node, you want to do a Foreign section, you can do it. Number two, because when we do the lymphadenectomy, the entire vascular tree is your uh, at your hand. So it means that you can ligate the uterine artery at its origin. And once you finish that, it is very easy to do the pararectal space development. So that also is the step that you should not forget. Finally, once the lymph nodes are also removed, you do an intracorporeal suturing of the vagina. So this is the steps of the procedure. Let's just rewind the pelvic lymphadenectomy, its limits. Before we go on to the pelvic lymphadenectomy, so what are the extent? What is the extent of the pelvic lymphadenectomy? You should know. Normally, pelvic lymph node dissection starts from the level of the branching of the common iliac vessels. So from there, that is your superior extent. Inferiorly, we go up to the pecten pubis. So from the common iliac level, artery branching to the level of the pecten pubis, this is the superior and caudal and cranial extent, I must say, caudal and cranially. And then laterally, the limiting factor is your genital branch of the genitofemoral nerve. Medially will be the ureter. So until the level of these completely, you have to remove the common iliac nodes, external and internal iliac nodes, including the obturator and the deep obturator tissue. Once you have identified the obturator nerve, we don't go beyond that because that is where you will have the internal iliac veins. Just keep this in mind. We'll go through this video. So this is the just pausing here. So what you have found is that the retroperitoneum is opened. Okay, you can find that the ovaries are here. This is uh, the ovarian plexus of vessels. Once they are on vision, you have made out the dissection. You proceed with the. You can see that the surgeon is clearly going in the pararectal space. The lymph nodes are delivered as a package. Okay, so delivered as a package. This is the external iliac artery and vein. Okay, so these are the lymph nodal packages that are being developed. So many a times we don't really use much of a energy device unless we require. With careful dissection, either a suction or even a instrument as a closed instrument like this, you can use as a blunt instrument to clear the lymph nodes. What is necessary is that you have to do it in a very gentle way. If you go in the right plane, it will get lifted up like this. So we're going up these tissue, the lymph nodal package is being delivered. Okay. We go up to the level of the pecten pubis. This is an energy device being used. So that's a pelvic lymphadenectomy completed. So remember that these are all edited videos. This is where you have to keep in mind that edited videos are short procedures. This is a patient with a cervical cancer. Remember that normally in an endometrial cancer, we talk about not using myoma screw at all. But we have a very early cervical cancers. For ease of doing the surgery, you can use a myoma screw, but be very clear that you don't go very low and you don't keep changing the positions, because if you go on laterally or if you go too close to the cervix, then you're in trouble. So if you can put it on the fundus of the uterus, you can do it in a clear way. So this is what we do. The the UV fold of peritoneum is open. As we open only, we are able to see the ureter. So remember that you can see the peristalsis on the ureter that is thing. These are the vascular sheath of vessels that go on the top of the ureter. The peristalsis is very, very important. That is your clear indication that you are dealing with the ureter. Once you do, then we start the posterior U cut as well from the right to the left side of the IP ligament. So this is the posterior U cut that they're talking about. Always we say that the non-bilious fascia has two layers. That is the fascia which is there between the endopelvic fascia lining between the rectum and the uterus. Generally, the fat belongs to the rectum in case you're not doing it posteriorly, and the fat belongs to the bladder when we're doing it anteriorly. If you go in this plane, we'll be going in the correct plane of division between the two layers of the endopelvic fascia, thereby maintaining the radicality and also making sure that we don't damage the adjacent rectum or the bladder. So we go in this plane, we go until the level of the levatrine. So this is what is being done. The parectal spaces are being defined. See the use of, so this is what I talked to you about, the external iliac vein, and this is the takeoff of the internal iliac artery, the first branch which starts the uterine artery. Remember that you have about a 2 centimeter. See, we go up to the levatrine muscle. Remember that this, sorry, just remember that the length of the internal iliac artery, it is about at least 2 centimeters from its origin before you have the uterine artery. So you will have enough space if you even want to ligate the internal iliac artery. That is the case when you do a internal iliac ligation in a postpartum hemorrhage. So in this situation, you're finding that the iliac artery is here, internal iliac artery is here. This is the uterine artery. So go in this space, we will be going the entire opening of the entire parectal base up to the level of the levatrine. You do that automatically, clip the vessel. The vessel is divided, parectal space is cleared, making sure ureter is free. The same procedure has to be done on the opposite side, making the anterior U cut. Okay, the uterosacrals are, the UV fold of peritoneum is open, and then we push the bladder away. So this is the steps that you will have to remember whenever we talk about the radical hysterectomy. Okay, so this is the uterine tunneling that we talk about. See the fact that we are using scissors and not using any tissue that is close to the ureter, we use scissors. Only on the periuteric tissue, when they are lifted up, we use diathermy. The edited video again, the lymphadenectomy being completed on the left side. The lymph nodal package is delivered, the specimen is endobagged, and then colpotomy is done, specimen is retrieved, and the vagina is sutured. So these are the steps of a radical hysterectomy. Now remember that the surgery may appear to be simple for those who have not understood the radicality of the surgery. It is in terms of surgical oncology training or a gynae oncology training, one of the surgeries which really take a lot of training before you are handed over your first case of a Wertham's radical hysterectomy. Reason is you have to be meticulous, you have to be very, very patient, and any compromise can injure the ureter or the rectum and the bladder. Nerve sparing radical hysterectomy requires a lot of training, and we cannot compromise the radicality of the surgery. So it's a very complex surgery, and the morbidity can be really bad if we do any mistakes. The complications can happen despite your best attempts, even in the best of hands. So generally, whenever somebody is asking you about a procedure like this and the complications, always try to classify. This is the best way I would suggest to any question as well. When a question like this is asked in a theory question, for example, complications of a Wertham's radical hysterectomy. If you start writing an essay question or a short note, and you don't know what to write and what not to write, classify. Most often than not, you will not miss many things. So the complications, you can classify them as intraoperative, immediate post-operative, delayed post-operative, and late complications. Intraoperative complications can be mainly in terms of injury to the major vascular structures. That could be the internal iliac artery, internal iliac vein, common iliac artery, or the external iliac artery and vein, uterine artery bleeding, very rarely superior vesical artery injury. So this is about the vascular injuries. And you can devascularize or injure the ureter, ureteric transections, bladder injuries, rectal injuries. So all these are things that can happen when you do a intraoperatively, the bleeding, hemorrhage. These are complications that can happen intraoperatively. They can be a nightmare sometimes if you're not trained or you don't have a helping hand. Immediate post-operative complications include, the most common one is your the paralytic ileus. That is the most common post-operative issue that we face. You can have high drain output because of bleeding. Rarely, you can have injury to the uh, ureter or the bladder that can present as a urinoma in terms of either a wall discharge, or if you have placed a drain, you will be having a high output urinary drain through the uh, pelvic drain that you keep. Very rarely, delayed post-operatively, you can have delayed uretrovesical uh, uh, uterovesical fistulas, uretrovaginal fistulas, and so on. Rarely, rectovaginal fistulas as well. These are all delayed post-operative complications. Additions, uh, uh, additions in terms of intestinal obstruction producing complications or vascular malformations. If you have missed out a small bleeder, you can have a pseudoneurysm developing. All these can be late complications. So when you take up a complications as a classification, you will be able to write about them. Each complication, accordingly, you can tell as to what will be the effect, how will you manage, and that makes you write a good theory question as well. Now, if you're not able to do that, these are the common things that you should remember. The common complications, it will be bleeding, wound infection, bladder hypotonia. As I told you, the plexus, if you're not very careful with regards to the bladder tone, with regards to the preserving the plexus, parasympathetic plexus, you can have a bladder hypotonia. So the patient will present you with overflow incontinence. That is, they will not be able to perceive the filling of the bladder, and they will present as incontinence after a full bladder. So these require sometimes prolonged catheterization and parasympathetic blockade drugs. Usually they'll recover, but very rarely these patients, some of these patients, if the parasympathetic is divided on both sides, they may have a prolonged hypotonia. Urinary fistulas, as I mentioned, uretrovaginal or vesicovaginal fistulas, rarely are rectal fistulas. Lymph cyst is a very common complication whenever a pelvic lymphadenectomy does, either for a endometrial cancer or for a radical cervical cancer. Essentially, is nothing but the lymph, which is going to be collecting around the iliac vessels. Mostly they are asymptomatic, but sometimes when they are large enough, significant amount is made out and they are producing pressure effects, they need to be aspirated, or sometimes even a pigtail catheter drainage may be required. Small bowel obstruction and deep vein thrombosis is something that you have to keep in mind. So whenever we talk about a Wertheim cystectomy, it is also important that the preparation of these patients. So how do you prepare these patients for a major procedure like Wertheim's? You have to make sure that you avoid a deep vein thrombosis. So we usually start low molecular weight heparins, usually about 8 to 12 hours. Very comfortable starting the low molecular weight heparin using a mechanical devices, like if you have the facilities like continuous pneumatic air, continuous pneumatic lower limb DVT prophylaxis with sequential calf compression devices, or a thromboembolic deterrent stockings, they should be applied. Preparation of the surgery in terms of correction of anemia or hyperproteinemia before any major surgery should be done, like any other case. The bowel preparation, if you ask, most often than not, we usually don't give a major bowel preparation. Usually a low residual diet and sometimes an overnight enema is all that we normally use. In case you're going to do it by minimal invasive techniques and you don't want a loaded colon, then you're justified using a uh, preparation with a coloprep or a peg leg preparation. But usually we make sure that at least 24 hours before the preparation is done. Otherwise, you can have a gaseous distension of the bowel that will hinder your surgery. So these are things that, like any other surgery, that you have to keep in mind. Now, we were discussing about the cancer cervix surgery, the safety of the minimal access surgery. So prior to 2017 and 18, I was doing a lot of these surgeries by minimal access, but this particular the LAC trial, that is the laparoscopic approach to cervical cancer trial, actually made a significant change in our practice. So what was this? This was the randomized control trial which compared minimally invasive techniques, either laparoscopic or radical hysterectomy. It was compared with open radical hysterectomy in women with early stage cervical cancer. It was basically a non-inferiority trial of minimal invasive surgery compared with the open floor. And the primary endpoint was disease-free survival at 4.5 years. In the minimal invasive surgery group, majority of women who were treated by conventional laparoscopy, that is 84%, whereas 16% women underwent robo-assisted surgery. So this is uh, the split between the laparoscopic type and the robotic type. Originally, 740 patients was the sample planned. However, the trial was prematurely stopped because of some data from the safety monitoring committee as early as November 2017, where after an interim analysis, there was a significant lower disease-free survival and overall survival in the minimal invasive surgery group. That is, you're talking about a minimal invasive access surgery group. That is a laparoscopic and the robotic cancer group compared with the open surgery, we're having a lower disease-free survival and overall survival. This was the reason why most of the time we are now not doing the minimal access surgery for a cancer cervix, and unlike in a cancer of the endometrium. So this was a video which was shot much before that, and nowadays most of the time, because of this particular trial, we are not doing it as a routine. Now, at the time of the termination, 85% patients had already enrolled into the study. Significantly inferior results with the minimal invasive surgery compared with the open survival with the open route was that. That is 86% versus 96.5%. So very, very significant survival that we are talking about in terms of disease-free survival. And even in terms of overall survival, the minimal invasive surgery group compared to the overall open surgery group was 93.8 versus 99%. So you're talking about at least a 6%, 5.2 to 6% OS difference. So that makes it's a significant difference. And for this reason, we're not doing it by a minimal access surgery. There are a lot of flaws with this trial. The way the surgery was done in multiple centers, the surgeons have not been trained, uniform training was not there. So the radicality of the surgery was not ensured across in all the centers. There are multiple flaws in this trial, but unfortunately, we don't have still randomized control trials which have actually compared open with the lab and proven the lab or robotic and proven the benefit of overall survival and DFS in terms of safety. For that reason, we still are not able to do it laparoscopically or robotically. I'm sure it's a matter of time that, as in the case of rectum cancers, where initially there was a lot of resistance towards doing the same, or an endometrial cancer, where the uh, survival was questioned, has stood the test of time, and we are now saying that they are equally good. In fact, in uh, endometrium, minimal access surgery is probably the preferred technique in case of early cancers. Now, in the LAC trial that we are talking about, minimal invasive surgery, radical hysterectomy was associated with higher rates of all-cause mortality, disease-specific mortality, and loco-regional recurrence compared to open surgery. These were the reasons why this la lap or a robotic cervical cancer surgery was not pursued further. Now, with this, I've completed this talk on operative surgery for cancer of the cervix. Now, it's a very exhaustive topic. I thought I'll just give you a prelude on what are the indications, what are the steps, how do we select the cases for a radical hysterectomy, the steps of the surgery, the complications of the surgery, and how we take it forwards from in terms of a minimal access surgery. Now, if there are questions on the YouTube, I will be happy to take them. Take it forwards from in terms of the minimal access surgery. Now, if there are questions on the YouTube, I will be happy to take them. Take it forwards from in terms of the minimal access surgery. Now, if there are questions on the YouTube, I will be happy to. Any queries? Any queries?